this is about take 4, although you guys didn't have to sit through all the other takes. Hopefully everything is up and running now, and so we're going to do a little bit of review of second semester's Intro to Kinesiology. I'm going to look at some of the major concepts that I want to make sure that you're bringing forward with you into third semester PTA 200. First thing we're going to talk about is osteokinematics versus arthrokinematics. There we go. And osteokinematics being your gross movements. So where the bones are either approximating or they're moving distally. So these include flexion extension, abduction adduction. It can be circumduction, supination, inversion. These are all motions that are under volitional control. Okay, the patient or the person is able to do these actively and under their control. Arthrokinematics, however, is the movement between the joint surfaces. So this is not under voluntary control, but it does occur to allow full range of motion of the osteokinematic motion. So the role in the swing is the direction of movement of the bone. So swing may be a new term, but it's also used in place of roll, and I'm thinking it might be easier for you to visualize a swing as opposed to a roll. So say with shoulder flexion, the humerus is moving anteriorly, so the swing or the roll is also anterior. The glide depends on the shape of the surface that is moving in relation to the shape of the surface it is moving upon. So we'll get into the convex concave rule a little bit later. But again, it happens within the joint, at the joint surfaces. Spin at the joint surface is where one bone rotates around essentially one stationary point on the other bone. End feel. There's normal and abnormal. Normal end feels include bony, which is your kind of hard, abrupt end feel, still through full range of motion. An example of this is elbow extension. Your firm or muscular normal end feel is that which is not necessarily restricted, but controlled by muscle. So you're going to feel a little forgiveness at the end, but it's very firm, and this is kind of like dorsiflexion with the limitation of tightness in the gastroc. Then your capsular leathery end feel is going to be something like shoulder flexion, where you get it to the end range and there's still some forgiveness there, but it's a strong forgiveness, so it's like you're pulling on leather a bit. Soft tissue approximation is your soft tissue kind of acting as a bumper at the very end of range. So biceps with elbow flexion. In hip flexion, it could be the quads or even abdominals if they have a lot of soft tissue in the abdominal region. And that could start to limit that end feel. Now, abnormal end feels are going to be bony as well, but this bony is also going to be hard and abrupt, but it will be before the end of range of motion. Muscle spasm is just what it says, is that muscle starts contracting and goes into spasm before you can reach the end of range. Capsular, similar to a normal capsular end feel, however, it's going to be before the end of range as well. An empty end feel is one where the patient is experiencing a lot of pain, or it could also even be apprehension, but that patient's not going to let you go to the end of range. You feel like you can, but the patient doesn't allow you, and that's an empty abnormal end feel. A boggy abnormal end feel is one where there's swelling present. So that joint almost feels like a big wet sponge, and there's a little bit of bounce. It almost feels like the joint isn't quite congruent because there's so much fluid in there. A springy end feel is usually an indication presentation of a torn cartilage, labrum, meniscus, where before you get to end range, the bone and the joint actually kind of springs back on you. So those are end feels. Convex concave rule. Now, I highly, highly recommend that you spend a little bit of open lab time pulling the bones out of the cupboard and going through different joints, moving convex on concave surfaces and vice versa. This, I think the wording here is a little different than what I've given you before, just to kind of hopefully bring another angle to this. But essentially, if it's a convex surface moving on a concave surface, okay, convex concave surface, the direction of the glide is opposite the direction of the movement of the bone. If the bone surface is concave moving on convex, your glide is going to be in the same direction as the movement of the bone. Again, take a look at some joints. Really, really drive this principle home, okay? And everyone's favorite, passive and active insufficiency. So passive and active insufficiency only occurs with two joint muscles, okay? A muscle that actually crosses two different joints. Passive insufficiency is when you try to stretch this two joint muscle over both joints, but both joints cannot reach full range of motion when that muscle is being stretched over both of them at the same time. Active insufficiency is where a muscle is contracting. So the patient is trying to do this actively, but again cannot reach full range of motion of both joints at the same time. Okay, here's a little a link to a little video that might be helpful for you as well, just again to get another presentation on the same concepts. Joint mobilization. It came to my attention that I talked about joint mobilization but didn't always really define joint mobilization. So joint mobilization is a manual therapy technique used to increase the arthrokinematic motion of a joint to ultimately then increase the motion function of the osteokinematic motion. So there are different passive movements that we use to try to increase the arthrokinematics of a patient. And we'll definitely go through these specific techniques towards the end of third semester. So, but as we think about it and you define the direction of the glide, if that patient is limited in a range of motion, the joint mobilization is usually done in the direction of that limitation. Whatever the glide limitation is, it's usually mobilized in that direction. So hopefully I didn't make that any more confusing for you. Okay, so those are pretty much the main 5 major concepts that I want you to carry forward. Few others that you need to review that I didn't feel like I needed to lecture on are directional terms. So your anterior posterior, superior inferior, deep superficial, those things. Your planes and axes, so movement in one plane occurs around which axis. Axial and appendicular skeleton, which bones belong in which part of the skeleton. So, are your ribs part of the axial or the appendicular skeleton? There will be questions like that on the quiz. Osteokinematics, other than what I mentioned before, I'm not sure why I have this on the list, but again, make sure you know what osteokinematic motions are, what is included in that category. And then types of joints, both structural and functional types. So everything from diarthrodial to ball and socket to fibrous. Pull out that table that you have and review your types of joints. And then your last question or your last topic would be types of muscle contraction. This includes isometric, isotonic, eccentric, concentric, isokinetic. Okay, and be able to identify the type of muscle contraction in different movements. Okay, so that is it for your intro to Kines review. Hope you enjoyed it as much as I did, and you can take the quiz on Blackboard anytime you're ready. Thanks for listening.